Yeah, so lymphoma is, one of those areas where, I mean, a lot of hospitals, they don't have a lot of exposure to hemato-oncology. So I know that, many people that I've spoken to, they are a little bit not so confident, not so sure about lymphoma. That's one area. But it's, unfortunately, for better or for worse, it is a part and parcel of these practical exams. So you do need to know things. Now, lymphoma, the topic itself is vast, right? So it is important to know what to study and what is important for the practical exam. That is the most important thing that you need to know here, and that is what we're going to deliver in this session today. Okay. So remember this in mind. If you know what to study and how to present, then things will go smoothly. So you don't have to worry about knowing entire lymphoma in its entirety. That's not required for your practical exams. Okay. So without any further ado, we'll just start off. Dr. Puran, please proceed.
So I'm presenting the case. 53-year-old lady from Delhi, homemaker, and no known comorbidities. Her chief complaints are swelling on the right side of the neck since 2 months, foreign body sensation in the throat since 1 month, and a fever since last 1 month. History of presenting illness. The patient was fine 2 months back when she noticed swelling in the right side of her neck, which was rapidly progressing in size, and the swelling was associated with mild pain. Patient also complains of foreign body sensation in throat since 1 month with progressing severity and associated with pain and swallowing. Patient also complains of fever since 1 month, low grade, intermittent with temporary cessation on taking antibiotics. Patient has received 2 courses of antibiotics for the same over the course of 2 months. Now, history of presenting the negative history. There is no history of swelling in oral cavity, no history of nasal obstruction, headache, ear pain, no history of difficulty in swallowing, no history of hoarseness of voice, no history of cough, breathlessness, or hemoptysis. Past history, there's no history of similar symptoms in the past, no history of any surgery or transplant, no known allergies, no previous malignancy history. Personal history, decrease in appetite, bowel and bladder functions are normal, diet mixed, and no addictions to any substance. Family history, not significant. And the summary from history, patient is a 53-year-old lady with history of rapidly progressive swelling in the right side of the neck since 2 months and foreign body sensation in the throat since 1 month associated with painful swallowing and intermittent low-grade fever since 1 month.
Okay. So we have a 53-year-old lady here, middle-aged lady with no known comorbidities who has a, rapidly progressive swelling on the right side of the neck since 2 months, associated with a foreign body sensation in the throat. And there's also intermittent low-grade fever since 1 month. That is not explained by any other cause. Okay. So now let's look at all the possible questions they can ask you, in this particular scenario, right? So the first thing is age. When it comes to lymphomas, um, what is the age distribution of various types of lymphomas?
So age mainly in Hodgkin lymphoma, it is bimodal age distributions in young like 15 to 34 years and in older age more than 55 years. And also in ALCL, there is bimodal distribution is seen in children's and old age people. And in primary mediastinal B-cell lymphoma, we most commonly see in 30 to 40 years of age, females are more likely to have this lymphoma than males. And Burkitt's lymphoma, we usually see in childhood, like 5 to 15 years of age, and also in HIV positive young adults. And
Yeah. So I think you've listed most of them. That's the answer we're looking for. So basically, most of the lymphomas, the majority of the lymphomas occur after the fifth to sixth decade. Okay. So that is the general answer, but there are exceptions to this. So the most common one is Hodgkin's disease, which has a bimodal age distribution, most commonly in people in the second and third decade, can also occur in the fifth decade. Then you have got ALCL, like you mentioned, also has a bimodal distribution. Then you have got primary mediastinal B-cell lymphoma, which occurs in the third to fourth decade. right? You've got Burkitt's lymphoma, which occurs mostly in children, right? You have also got lymphoblastic lymphoma, which is a very aggressive type, which also occurs mostly in the second to third decade. So mostly, 50 and above, but these are the exceptions. Hodgkin's disease, ALCL, Burkitt's lymphoma, lymphoblastic lymphoma, primary B-cell lymphoma. So those are some examples you can quote. Okay. Now, what is the role of occupation and lymphoma? How is that related? Is there some correlation there?
Occupation in case of exposure to pesticides, farmers,
Yeah.
or any.
So you're right. So all sorts of benzene, toluene, pesticides, organic solvents, people work in the petroleum industries, painting, dry cleaning, etc. There's seen to be a correlation with developing lymphomas. Okay. Now coming to this next thing, this is a very important question here. What is the uh, importance of duration of a neck swelling or any swelling, which we assume to be a lymph node swelling? So what is the importance of duration there? What are we trying to signify in the context of lymphoma?
Duration, if it is acute, then it is most likely due to inflammation or any
Yeah,
yeah,
from
inflammation.
a malignancy point of view. So, like if you take a lymphoma, right, we know that there are aggressive types and there are indolent types, right? So the aggressive types will have, like you said, more of an acute presentation. So, 3 months, 2 months, or less than that. So you have classic is Burkitt's lymphoma, which has a turnover time of, a doubling time of 24 hours. Then your DLBCL, your aggressive mantle cell lymphoma, your lymphoblastic lymphoma, T cell lymphomas, all these will be very aggressive, right? And whereas on the flip side, if you look at the chronic lymphoproliferative disorders like follicle lymphoma, marginal zone lymphoma, indolent mantle cell lymphoma, small, like your CLL base, SLL, lymphoplasmacytic lymphoma, etc. All these are BCLPDs. Tend to have a chronic, so the history will be longer. You'll see a history of about 6 months to 1 year and more. Whereas in your aggressive lymphomas, like the ones I mentioned, you'll see history of less than 3 months, right? So even in this patient, you can see that the patient has a 2 month history uh, of the same. So here I'll just like to quickly mention, I mentioned mantle cell lymphoma in both indolent as well as aggressive. So what are some of the features in mantle cell lymphoma that point towards an aggressive variant of mantle cell lymphoma? We know that 90% of them are, 85 to 90% are aggressive, only 10 to 15% are indolent. So what are some of the features that point towards aggressive variant of mantle cell?
So,
I'll just fill you in there. So, there's a MIPI score. So if the MIPI score is high, then if, Ki-67 is greater than 30 percentage, if it is TP53 positive, SOX11 positive, if there's the LDH is raised, if you have, you know, like presence of nodal involvement or extranodal involvement, right? The leukemic variant where count is raised is considered to be indolent, whereas nodal and extranodal involvement is considered to be aggressive. Then, of course, there's specific subtypes like blastic and pleomorphic that are more aggressive, right? So that's that. Now, coming to the next symptom here, the patient has fever since 1 month, right? Um, so, what is a definition of B symptoms?
the symptoms are fever more than 38 degree Celsius for 4 weeks, and drenching night sweats, and weight loss of more than 10% in last 6 months.
Yeah. So basically, fever 38 degrees, 100.4 degrees Fahrenheit, drenching night sweats, and weight loss of greater than 10% in less than 6 months, which is not explained by any other cause, right? That also has to be mentioned. So, which type of lymphoma, like overall, looking at the bigger picture, which type of lymphoma is more associated with B symptoms?
Classic Hodgkin lymphoma associated with
Yeah, so that is
50%.
about, yeah, so 30 to 40% of early stage Hodgkin's and around 70% of advanced stage Hodgkin's is associated with B symptoms. Now, amongst your non-Hodgkin's lymphoma, important thing to know here is that B symptoms are usually seen with the aggressive variants in the non-Hodgkin's lymphoma category. Okay, whereas the BCLPDs you usually won't see B symptoms on presentation, right? So aggressive variants of non-Hodgkin's lymphoma like DLBCL, mantle cell lymphoma, and Burkitt's lymphoma, around one third of these aggressive variants of non-Hodgkin's lymphomas, they have B symptoms. Whereas most commonly you see it in Hodgkin's, like you said. Okay. Now, moving on. What is how where in what sort of scenario do you see B symptoms in indolent non-Hodgkin's lymphoma?
DLBCL.
So like suppose there's an indolent non-Hodgkin's lymphoma that they don't have it, but suddenly they develop B symptoms. So what do you suspect in that scenario?
Transformations.
Yeah, so that's the
Disrupt.
number one thing that we need to look for. There is a lifetime. For example, if you take follicular, there's a lifetime risk of around 5 to
One,
10
two.
percentage of
Yeah.
transformation. So what are the some of the signs and symptoms that you'd see in a suspected case of transformation?
There is a rapid increase in the size of the lymph nodes, symptomatic, and B symptoms.
Yeah, so rapidly enlarging nodes, B symptoms, there'll be fatigue, there'll be hepatosplenomegaly, there'll be sudden extranodal involvement, there'll be an increase in LDH. So all these symptoms point towards transformation. Classically, it's called Richter's transformation. It is classically described in um, your CLL, and but it's now applied to all indolent lymphomas. Right. So, what is the most common lymphoma into which transformation occurs?
Mostly follicular lymphoma.
As in the transformed lymphoma, which histology is most commonly seen there?
DLBCL.
Yeah, so it is most commonly DLBCL. Okay. So the next thing that we like to talk about is this patient has a foreign body sensation. So in the context of lymphoma, that looks like some sort of extranodal involvement. So where do you see um, extranodal invasion? In which type of lymphoma do you see it?
High grade DLBCLs.
Yeah, so you basically, unlike B symptoms, you see external invasion in non-Hodgkin's lymphoma more than Hodgkin's lymphoma
Hodgkin's.
overall. And within non-Hodgkin's lymphoma, you see it in aggressive variants. Okay, those have a higher propensity to have external involvement. Okay, so aggressive variants of non-Hodgkin's lymphoma is that's where you most commonly see it. And in Hodgkin's disease is less common. Which variant of Hodgkin's disease has a higher chance for external invasion? So your
Multiple sclerosis.
so the worst prognosis, the one with the worst, there's lymphocyte depleted. Okay, that has a it's got a bad prognosis and it has a high chance for external invasion. Okay, so we said aggressive NHL as the most common. So if you look at DLBCL, 1/3 of the cases have external invasion. Most common site is GI. Burkitt's lymphoma, around 40 to 50% have external involvement. It can be in the form of jaw, the GI, or CNS, and mantle cell lymphoma, it is around once again 1/3. So all these, it's 1/3. Burkitt's, it's the highest. It's around 40 to 50%. Now I want to ask you, uh, CNS external involvement, where is it most commonly seen?
In Burkitt's lymphoma.
Yeah. Okay.
And
And so Burkitt's lymphoma is it's you give CNS prophylaxis in the
yes,
treatment because it has a high chance for CNS B
Burkitt's.
cells. So which lymphoma has the highest, which aggressive NHL has the highest chance for bone marrow involvement? So it's most commonly seen in like mantle cell lymphoma. Okay, around 60 to 70% can have bone marrow involvement. Now, what are some of the risk factors that can increase the chance for CNS involvement? So, what all areas can be involved that can increase the risk for CNS involvement?
Okay. Like testis,
Yeah. Okay.
testicular, breast,
Yeah.
uh,
Yeah. So you're right. So like kidney,
kidney,
adrenals.
adrenal.
Yeah, breast, testis, ovary. Then if you have a paraspinal location, if you have nasopharyngeal location, that can spread through the cribriform plate. And if you have a high CNS IPS score also. In the case of DLBCL, high CNS IPS score. So all these are risk factors for high chance for CNS spread. Okay. Now, moving on. Right. So now coming to the location of swelling. Okay. Um, so Hodgkin's disease is seen on what sort of swellings do you usually, where do you get swellings usually? lymph node swellings?
Cervical lymph nodes most.
Yeah. So mostly supradiaphragmatic, and it's most commonly cervical. And it is contiguous involvement, right? Whereas in non-Hodgkin's, it's supra and infradiaphragmatic, right? There's no propensity as such, unlike Hodgkin's, which is most commonly in supradiaphragmatic and cervical. Now, which variant of Hodgkin's has mediastinal spread? It's the nodular sclerosing variant, okay. And which variant has retroperitoneal spread? It's mixed cellularity, okay.
Cellular.
Yeah. Okay, so that's some differences that are seen within the variants of Hodgkin's, but mostly Hodgkin's is supradiaphragmatic and cervical, whereas non-Hodgkin's can have supra and infradiaphragmatic involvement. Okay. So, what are the lymphomas that are commonly associated with the mediastinal mass?
Primary mediastinal B-cell lymphoma.
Okay.
Hodgkin's.
Yeah, nodular sclerosing variant of
Nodular sclerosis, Hodgkin's. And
and your lymphoblastic lymphoma.
lymphoblast. Yes.
Okay.
Mm.
Lymphoblastic lymphoma, it generally presents as a mediastinal mass. Okay, so those are some of the common variants where you can get a mediastinal mass. Now, one more thing I'd like to ask you: what are the primary cutaneous lymphomas that you know of under B cell and under T cell? Can you name three under each?
In T cell, there is a mycosis fungoides, Sézary syndrome, and
Yeah,
T cell lymphoma.
So you're right. So
And
cutaneous T cell, you have mycosis fungoides, you have Sézary syndrome, you have adult T cell leukemia lymphoma that can also primarily present to the skin. You have subcutaneous paniculatus like T cell lymphoma
Paniculatus, yeah.
that can also present. Then you have NK T cell nasal type that can also present in the skin. You have primary cutaneous ALCL that can also occur. Then you have primary cutaneous PTCL, not otherwise specified. Okay. Those are some of the primary cutaneous T cell lymphomas. Then B cell, which is what most of us not familiar with. Your primary cutaneous DLBCL, yeah. Leg type, yeah. And primary cutaneous marginal zone lymphoma and primary cutaneous follicular center lymphoma. Okay, so those are the primary B cell skin cutaneous lymphomas. Now, another thing I'd like to point out here is that so when you present the case of a a lymphoma, right? Mostly in the exam, you will get a patient with supra and infradiaphragmatic nodes or a patient with a neck swelling. Okay, that is what they mostly keep in the exams. So, of course, depending on the site of the swelling, right, you need to rule out like there are many organs or cancers of various sites that can drain to those lymph nodes, right? So, we need to rule out involvement of those sites. So, that's what we have done in the negative history here. Okay, so oral cavity masses, nasopharyngeal masses, anything of the foot pipe, hoarseness of voice, the larynx, the lungs. So all of that can also present with a cervical node. So that's why we rule out the negative history. So mostly if you get a cervical node, this is what you need to rule out. But if you get any other site, you need to rule out the primary malignancies that can drain to that particular node. Okay, where the swelling is occurring. So remember that. Now, moving on. So coming to past history, I'm going to ask you a very important question. Can you tell me the role of infections in lymphomas? So what are the type of viruses associated with lymphoma? What are the type of bacteria? So we'll start off with the viruses. I'll give you number one, EBV.
EBV associated DLBCL.
Burkitt's.
Burkitt's.
Yeah,
Burkitt's.
Yeah, mute your mics so we don't all talk over each other. So I'll just break it down. Okay, so when you say EBV, you should say it as latency 1, latency 2, and latency 3. So those three sets of genes give rise to different lymphomas. So latency 1 is Burkitt's lymphoma. Latency 2 genes is classic Hodgkin's disease, NK T cell lymphoma. Okay, latency 3 genes are DLBCL and post-transfer lymphoproliferative disorder. Okay, so that's EBV associated lymphomas. Then you have HTLV1, which gives rise to
human T cell leukemia lymphoma.
Yeah, so ATLL, right? Classically, it's
हाँ,
gives rise to ATLL.
T cell
Then
lymphoma.
hepatitis C
It's
gives rise to
mar
splenic
mar
marginal zone lymphoma,
marginal zone lymphoma.
lymphoplasmacytic lymphoma. Okay, and then you have your
HSV8
yeah gives rise to
primary fusion lymphoma.
yeah, and multicentric Castleman disease. Okay,
Castleman disease.
yeah.
Yes.
So then the most important one they tend to ask is HIV. Okay.
HIV.
Okay, so that's an important area. So before we get into lymphomas, what are the HIV defining cancers?
HIV defining cancers are other systemic lymphomas like DLBCL, Burkitt's.
Okay, so aggressive
Yeah.
non-Hodgkin's lymphoma. Okay, so
Okay.
that is
Aggressive
one.
non-Hodgkin, yeah. Then primary CNS lymphoma.
Okay, so all of that comes under aggressive non-Hodgkin's lymphoma. So then
Okay.
next.
Kaposi sarcoma
Okay.
and primary fusion lymphoma.
Okay, so lymphoma we already said. So I'll just say it, Kaposi sarcoma, then aggressive non-Hodgkin's lymphomas, and CS cervix. Okay, so those are the HIV defining cancers. Okay, those three. Now, when it comes to the lymphomas associated with HIV, you have Burkitt's lymphoma, you have primary CNS lymphoma, you have DLBCL, and you
Plasmablastic.
have plasmablastic lymphoma. Okay, so those are the common ones that are associated with HIV. Excuse me. Now coming, so know your viruses, know your lymphomas. They'll definitely ask this question. It's very commonly asked. Then bacteria. So bacteria, I'll just quickly mention. You have H.
H.
pylori, which
pylori.
causes gastric maltoma, right? Then you have
Yes.
some other ones like you can just mention
Chlamydia.
Borrelia burgdorferi, causes skin maltoma. Chlamydia can cause
Chlamydia.
ocular adnexal maltoma,
Ocular.
right? So all that. So know your viruses and bacteria. Now, what is the importance of asking history of transplant here?
Post-transplant lymphoproliferative disorders
Okay.
after solid organ transplantations.
Yeah. So post-transplant lymphoproliferative disorders, right, usually occur 1 to 3 years post-transplant, usually with solid organ transplants, and they're very aggressive. They rapidly enlarging lymph nodes. They have present with complications like SVCO, spinal cord compression, associated with B symptoms, right? They're divided into various types: monomorphic, polymorphic, early lesions, and Hodgkin's disease variant. Okay, so these 4 types. After that, monomorphic has the most poorest prognosis. So just know that much. Treatment, I'll just mention here quickly, is, what is it?
CHOP.
Withdrawing the immunosuppressant first. Okay.
Okay.
So you have to first withdraw the immunosuppressant, and usually that is enough to take care of the lymphoma. Some aggressive variants like monomorphic variant, you might have to add single agent rituximab or R-CHOP as well. But for the less aggressive variants like polymorphic, you just need to withdraw the immunosuppressant. Okay. Okay. So now coming to the family history, are there some inherited conditions where there's a risk for lymphoma?
Some syndromes like Chidiac-Higashi syndromes,
Yeah,
Wiskott-Eldridge
yeah.
syndrome.
Ataxia telangiectasia, combined immunodeficiency syndromes, right? So all that gets associated, and also some DNA repair deficiencies like Li-Fraumeni and Bloom syndrome, right? So those are the ones. No. Okay, now moving on. So based on this, so how to give your DD, right? So based on these symptoms, rapidly progressing swelling on one side of the neck, foreign body sensation in the throat, associated with painful swallowing, and intermittent low-grade fever, right? So there are 2 DDs that should come to your mind at this point. So, uh, you have a lymph nodes, neck swelling and fever. So this is lymphoma. But you also have this foreign body sensation in your throat, right? So that points towards it could be an oropharyngeal malignancy, right? So, but we know that. So when you mention DDs with this history, okay. So play off the history, whatever history you've got, use your common sense. So with this history of foreign body sensation and neck node swelling, I would, go with number one with nasopharyngeal carcinoma. Reason being that the incidence of nasopharyngeal carcinoma is much more than, sorry, I'll go with oropharyngeal carcinoma, right? Oropharyngeal, sorry. And because reason being incidence of oropharyngeal carcinoma is much more than that of lymphoma. Okay. So number one DD at this point would be oropharyngeal carcinoma. If suppose this patient had, some infradiaphragmatic swelling, as suppose inguinal node swelling, that would put lymphoma number one. Okay. But with this supradiaphragmatic neck node swelling only and foreign body sensation and just low grade fever is there, based on incidence, I would like to give a DD of oropharyngeal carcinoma. Second DD will be lymphoma. Okay. So that's my order of DDs just based on the history. Because we only have one site of nodal swelling and foreign body sensation. Okay. Now they'll ask you what are, okay, you can mention like that. What are the, um, what type of lymphoma could this be?
As it is associated with B symptoms, then it most commonly Hodgkin's, classic Hodgkin lymphoma.
Okay, so you need to take, so when you mention the type of, take all the things into account. Okay, so number one is the incidence. Uh, Incidence of non-Hodgkin's is more than Hodgkin's. Number two is the age. This lady is middle-aged, right? So as we know, middle-aged more commonly have non-Hodgkin's. Then the duration of symptoms is also very important. Hodgkin's also, it can be aggressive, it can be indolent as well, but more likely with a 2 month history is an aggressive NHL. Okay, they have a very aggressive course of less than 3 months. Now, another thing is, yeah, B symptoms are in favor of Hodgkin's, but you can also get that in an aggressive NHL, right? Although overall Hodgkin's has more B symptoms than NHL overall, but aggressive NHL has B symptoms as well, around 1/3 in most of the cases. And right. So basically, all these features would put it more in favor of NHL. The incidence of NHL is high, age is in the 50s, durations of symptoms is very short, right? And B symptoms can also be present in aggressive NHLs. So this is looking like an aggressive NHL. This is what you can argue based on the current symptoms right now. Okay. So DD of oropharyngeal carcinoma and second DD would be lymphoma. If they ask you what type, you can say an aggressive lymphoma, most likely to be an NHL. Okay. So that's what you can say based on these symptoms. I hope you got that point. Now, this is the most important question that they'll ask you in your practical exams. So what is the difference? What are all the differences between NHL and Hodgkin's disease? Can you
Uh,
list them out?
Yeah, from history we can differentiate like in Hodgkin's lymphoma it is main symptoms where this B symptoms will be there. In non-Hodgkin it is less common, and with in Hodgkin lymphoma there is history of pruritus, and where in NHL it is not that common, and and um,
Yeah, so I'll just
functional
quickly
model.
go over. We have a huge list actually.
Yeah.
So I'll just quickly
And
go over the important ones. Okay, so we'll start off from the top and go in order. Okay, so Hodgkin's, first of all, the age distribution.
age.
Hodgkin's is bimodal, young patients,
Mm.
second, third decade, and above the age of 50. Whereas NHL is mostly above the age of 50. Okay. Hodgkin's is always from B cell origin, whereas NHL can be B or T cell origin. Around 15 to 20% are T cell origin. Etiology, uh, majority of Hodgkin's disease, if the viral etiology is with HIV or EBV, okay, and HIV and EBV most commonly associated with mixed cellularity and lymphocyte depleted, okay, whereas NHL can be a wide variety of infections, HIV, EBV, HTL1, HCV, H. pylori, we've all discussed that, right? Now, coming to the clinical features, lymph nodes are usually supradiaphragmatic in Hodgkin's, whereas they are above and below the diaphragm in non-Hodgkin's. Okay. Contiguous spread in Hodgkin's, non-contiguous in non-Hodgkin's. B symptoms are more common in Hodgkin's disease, more common than NHL, but aggressive NHL also has B symptoms, right? So, but more common in Hodgkin's disease. Then, you have other features in Hodgkin's, such as Epstein fever, alcohol-induced pain in lymph nodes. You have pruritus, paraneoplastic syndromes that can occur, right? Then coming to extranodal invasion, it's less common in Hodgkin's, more common in non-Hodgkin's. Okay, hepatosplenomegaly is rare in Hodgkin's. It is more common in non-Hodgkin's. Especially hepatosplenomegaly in non-Hodgkin's is more common in the indolent non-Hodgkin's. Okay, hepatosplenomegaly. So just remember that. But overall, it is more common in non-Hodgkin's and Hodgkin's. Then coming to what do you call it? The prognosis, good prognosis in Hodgkin's, varied prognosis in NHL. Right. So these are all the things that you need to mention. If you mention 5, 6 points, the examiner will go on to the next question. So be ready with that answer, all these points that I mentioned. Just say it like a computer and they'll move on to the next question once you mention 5, 6 points. Okay. So just be prepared with that answer. They'll definitely ask this if you get a lymphoma, please. Okay. Um, okay, now moving on, let's move on to the examination part of it. Right.
General examination. Patient was examined in a well-lit room with consent with female bystander. She is conscious, cooperative, and well-oriented to time, place, and person with ECOG PS of 2. No pallor, no icterus. Right-sided level 2 lymph node 6 into 5 centimeter, irregular in shape, irregular surface, no tenderness, no increase in temperature, firm in consistency, matted with partial mobility in all directions. And left-sided level 2 lymph node 2 into 2 centimeter, irregular in shape, regular surface, no tenderness, no increase in temperature, firm in consistency, discrete and mobile in all directions. Right-sided multiple axillary nodes, 3 in number, largest 2 into 1 centimeter, oval in shape, regular surface, no tenderness, no increase in temperature, firm consistency, discrete and mobile in all directions. And bilateral inguinal nodes, 2 on the right side and 1 on the left side, largest 2.5 into 2 centimeter on the right side, oval in shape, regular surface, no tenderness, no increase in temperature, firm consistency, discrete and mobile in all directions. So vitals are temperature not checked, pulse rate 86, respiratory rate 20, blood pressure 122 by 84, saturation of 98%, Romeyer visual analog score of 4, pain over right neck swelling. Local examination, oral cavity, swelling is seen arising from the tonsillar fossa on both sides. The left-sided swelling is 3 into 2 centimeter in size and extending to involve the anterior tonsillar pillar. The right-sided swelling 2 into 2 centimeter and confined to the tonsillar fossa. Both the swellings are round in shape with a smooth surface. No ulcerations or discharge seen from the swelling. On palpation, there is no rise of local temperature tenderness. Inspectory findings were confirmed. Both masses are firm in consistency, non-fluctuant and immobile. The borders of the mass could not be palpated as the patient was reluctant. No abnormalities seen or palpated over the buccal mucosa, tongue, floor of mouth, palate, and other areas of oral cavity. On systemic examination, respiratory system bilateral clear, no added sounds. Per abdomen, no organomegaly, bowel sounds are heard. Cardiovascular S1, S2 heard with no murmurs. CNS system normal limit.
Okay.
So, summary of the case after examination. Patient is a 53-year-old lady with history of rapidly progressive swelling in right side of the neck since 3 months. Foreign body sensation in the throat since 2 months associated with painful swallowing and intermittent low-grade fever 2 months. On examination, she was found to have generalized lymphadenopathy with bilateral tonsillar mass.
Okay. So, like many questions to ask here. We'll come to the DDs right now. Um, there are many questions that can be asked here. So number one is, especially with cervical lymph nodes, you should know the levels of lymph nodes, right? The borders, right? I think we have discussed that in the head and neck topics. Quickly, I'll just go through it. Level one is, upper border is the mylohyoid and mandible and extend to the inferior border of hyoid divided by the digastric muscle. Level two is base of skull to the inferior border of hyoid separated by the IGV into level 2A and 2B. Level 3 is inferior border of the hyoid to inferior border of the cricoid. Level 4 is inferior border of the cricoid cartilage to clavicle, and level 5 is meeting point of um, the the sternocleidomastoid and the latissimus dorsus muscle, and inferior border is the clavicle, right? So the levels of cervical lymph nodes, just remember that. Now, very important question that all the old examiners ask is the consistency of the node, right? So when you present this, just a tip, you can mention the lymph node and the size. And if the rest of the features are the first lymph node, you can mention all the features. Remaining lymph nodes, if they're all the same, you can just say similar features. Okay, when you're presenting. When you write it down, you can write down everything. Okay, so consistency is very important. In NHL, it is?
It is a firm in consistency,
Yeah,
wherein
so
the
firm is
Hodgkin
the
is
word. Okay.
rubbery. Yeah,
Hodgkin's it is?
rubbery
Yeah,
consistency.
elastic or rubbery. And which which type is hard? Which
From solid malignancy,
the solid malignancies or T cell lymphomas. Okay, T cell
T-cell
lymphomas
lymphomas.
also have hard lymph nodes. So the consistency is very important. Hodgkin's is elastic rubbery. Firm is seen in non-Hodgkin's, and T cell lymphomas in particular have a hard consistency. Okay, so now another thing to know is what constitutes a significant lymph node. The criteria based on size. So for cervical and axillary, the size.
Cervical 1,
Yeah, so cervical and axillary is greater than 1. Inguinal it is greater than?
1.5. In binary it is 2 and
Yeah, inguinal 1.5 to 2, depending on the source.
1.5.
Epitrochlear it is?
That is 1.5.
Epitrochlear is smaller, so 0.5, more than 0.5. Okay. And for supraclavicular fossa or popliteal fossa, any size. Okay, is
Any
considered to be
size.
significant. So just know the size cutoffs there. That is important. Now, coming to how to palpate. So this is what they'll ask you in lymphoma, how to palpate or examine the patient. So I'll just quickly go. When you're examining the cervical node, right? Always stand behind the patient, use one hand. Okay. Don't press both sides of the neck. That's not the examiner will get pissed off. Use one side, one hand, your fingers on one side of the neck, and the side you're palpating, lean forward like this. So all the sternocleidomastoid relaxes. So you can palpate. Okay. So that's how you palpate. Stand behind the patient, use one hand, leave the other side, keep your other hand away and use one hand, bend the patient sideways so the sternocleidomastoid becomes relaxed. So you can palpate your cervical nodes. When it comes to supraclavicular fossa, you stand behind the patient once again and use your hands to palpate from behind. Okay. Coming to axilla, you stand in front of the patient. You keep the patient's arm over your arm like this and then palpate underneath. Okay. So keep the patient's arm over your arm and palpate underneath by standing in front of the patient. Now, when you come to epitrochlear nodes, right, which are located over here, you ask the patient to flex their elbow joint like this, and you stand in front of them and palpate. Okay. When it comes to popliteal nodes, you ask the patient to flex
Flex.
their knee joint. Okay. And then use both hands under the knee joint to palpate. Okay. I hope you got that, like this. Once the knee joint is flexed, you palpate underneath both hands. So the technique is very important for all these node groups. They'll ask you that. Okay. So now now coming to various other, the history presented like this, mostly. um, Now coming to various other tidbits. So lymph node examination is the most important thing. Then you might have a particular site if there's any external invasion that you might have to examine, right? Sometimes you might get splenomegaly as well. If especially if it's an indolent B cell lymphoma, you might get splenomegaly. So I'll tell you point by point some certain points you need to know. So bilateral tonsils is seen in this particular patient, right? Whenever bilateral tonsils is seen, it is more in favor of lymphoma than carcinoma. Carcinoma usually has unilateral tonsils. Okay. So just remember that point. Then splenomegaly, if you get, so you can, they can keep, various types of lymphomas, right? I'll tell you that later on what all they keep in the exams. So splenomegaly can be seen in indolent B cell lymphomas, right? So usually your BCLPDs like CLL, follicular lymphoma, splenic marginal zone lymphoma, indolent mantle cell lymphoma, all that can have splenomegaly. So in that case, you should know how to palpate your spleen. What are the features that you need to look for? You cannot get above the swelling. It moves with respiration. The splenic notch is felt, and it is not ballotable, which differentiates from the from a renal mass. So all these features you need to note down. You need to know how to palpate the spleen. Start off with the right iliac fossa, go towards the left hypochondrium, right? And also the hook method of palpation you need to know by keeping the patient in the right lateral position and using curling your fingers under the rib cage to palpate. Percussion, you should know about the drop space in the sixth intercostal space. You start off in the second intercostal space on the right side, go down to the sixth. If it is dull there, it implies the splenomegaly. If it is resonant, it implies that it's the fundus of the stomach. So that's percussion. Then you should know the grading of splenomegaly. Please refer to my splenomegaly case presentation on YouTube. You can, all the things are filled there. So that is all very important. Now, moving on. Right. So one more thing here is sometimes you might get an abdominal mass. Okay. So in that case, you should suppose you get an abdominal mass as lymphnopathy. So in that case, you should know how to differentiate between, in the per abdominal examination, you should differentiate between retroperitoneal or intra-abdominal location. Okay. That is done by the knee elbow test. When the patient is in knee elbow position, a retroperitoneal mass will become less prominent, whereas the intra-abdominal mass will become more prominent in the knee elbow position. Okay. Another test they can ask is the Carnet's test, which is by raising your legs, right? So if you raise your legs, if it's an abdominal wall mass, it will become more prominent, but an intra-abdominal mass will become less prominent. So that's the Carnet's test. Okay. And one more thing is, if it's a male patient, always examine the testis. Okay. They
Yes.
will look for that point in your exam. So always in lymphoma, lymph nodes should be examined. Then the site, if there's an external involvement, like in this case, we had tonsils, so we examined the head and neck oral cavity area. And suppose it's a perabdominal mass, you do a perabdominal examination. If it's splenomegaly, also you do a per abdominal examination. So always add your lymph node examination as well as your involved site if there's any other symptom. Okay, so that is how you write examination in a case of lymphoma. Now, so based on this summary here, now what will be your DD?
So my first differential will be NHL.
Yeah.
Uh,
So
Indolent
right now, it is the DD number one DD has switched over to
liver.
lymphoma, right? Because now we have the fact that you have supra and infradiaphragmatic lymphadenopathy. On
Yes.
examination, we had supra and infradiaphragmatic lymphadenopathy. That is more in favor of lymphoma, right? Then a oropharyngeal carcinoma, which is an initial DD. Then you have B symptoms. Then you have a bilateral tonsillar mass rather than unilateral, which is more in favor of a lymphoma involvement. Okay, so all these features put it towards a lymphoma, right? So now type of lymphoma is also very important. So like you said, there's extranodal invasion, there is B symptoms, and there's short duration of symptoms, right? So that looks like an aggressive NHL. Okay, especially because of the short durations of symptoms and the extranodal invasion, which is more commonly seen with NHL. B symptoms more common with Hodgkin's, but aggressive NHLs also have incidence of B symptoms. Okay, so because of these features, you can say my DD is most probably a lymphoproliferative disorder based on the suprainfradiaphragmatic lymphadenopathy, B symptoms, and bilateral tonsillar invasion. Based on the duration of symptoms and the B symptoms and external invasion, I would like to give a DD of, uh, further like to subclassify into a high grade, possibly non-Hodgkin's lymphoma. Okay. So that's how you'll state your DD. You can narrow it down to one DD at this point in time.
Because duration, how to cut off for the duration, like
See, there's no cutoff as such, but anything less than 3 months, it signifies that it's an aggressive variant. Okay, most commonly aggressive non-Hodgkin's. Okay. So now that you have done all of this, actually, more than the history and examination, this is one site where more than the history and examination, the workup and management is more important for your practical exams. This is what that one particular site. Okay. So start off with your workup for diagnosis and staging. What will you do for this patient?
for diagnosis, I would like to do imaging first, CT chest, abdomen, and pelvis. And then we'll go for LDH, blood tests like CBC and serum LDH, ESR, and LFT, KFT. For as it is aggressive lymphoma, we also have to look for TLS parameters, and then we'll do biopsy, and in case of high-grade lymphoma, the bone marrow is also needed. Not bone marrow, lumbar puncture,
Yeah. Okay.
and then
You've mentioned most of them. I'll just quickly, put in a. So when they ask you this question in the exam, so mention it in this order. Okay. So
Okay.
number one, it's an aggressive lymphoma. I will do my CBC, RFT, electrolytes, and LDH. Okay. Mainly, I'm looking to rule out TLS. So that's why I'd like to do that. Number two, I'll do the imaging. Always for lymphoma, we'll do a PET CT. Okay. So no CT scans, PET CT. This is one side you can say PET CT. Okay. And there are some lymphomas that are non-PET CT, of which they will ask you that. So they are, your
CLL, SLL, and marginal zone lymphoma, and
yeah.
WM.
So SLL, marginal zone lymphoma, mycosis fungoides, LPL, lymphoplasmacytic lymphoma. Okay. So all these are non-PET CT of which, but for the other vast majority, we do a PET CT. Okay. And so we have done our basic blood workup to rule out TLS. We have done our LDH, right? LDH can tell you about the aggressiveness of the disease as well. It's also a prognostic marker. Then second, we have done our PET CT. Now the third thing that we can do is bone marrow biopsy. Okay, so usually we do bone marrow biopsy in all lymphomas except for Hodgkin's disease because PET CT is sensitive enough and specific enough to detect bone marrow mets. Okay, and for DLBCL as well. So for Hodgkin's disease and DLBCL, we omit a bone marrow biopsy. Rest of the lymphomas, most of them we need to do a bone marrow biopsy. Okay, so just remember those two examples, Hodgkin's and DLBCL. Now, in Hodgkin's and DLBCL, where do we do a bone marrow biopsy? Like I said, PET CT is enough, but there are certain settings you need to do it. So if there is a cytopenia,
This unexplained
yeah,
cytopenia,
so
and if you suspect a HLH,
yeah. So you're right. So HLH, if you're suspecting, that's very rare. But most common thing is unexplained cytopenia. And if you have suspecting a concomitant low-grade lymphoma, okay, that can change the management. So if you have a concomitant low-grade lymphoma, you might have to give rituximab maintenance, for example, right? Along with the high-grade if you have concomitant low-grade. So if you're suspecting unexplained cytopenia, concomitant low-grade lymphoma if you're suspecting in the marrow, or if you have HLH very rarely, you can do a bone marrow biopsy. Those are all valid indications. Now, so next thing is biopsy to look at the node, right? So here you should always mention excision biopsy. Okay.
Excision,
So,
yes.
so we have done our blood workup, rule out TLS, LDH, PET CT, bone marrow biopsy where indicated. We can rule, not do it in Hodgkin's and DLBCL, except in certain conditions you need to do it even in those cases. Then excision biopsy. Okay, always do an excision biopsy, not a true cut biopsy. True cut biopsy is done where excision biopsy is not possible. Okay, because we need to look at the entire tissue architecture. So that's the answer why you should do an excision biopsy. Entire tissue architecture we need to do. We need to do extensive IHC workup and also molecular testing. So for all of that, an excision biopsy is what we prefer. Okay, mainly for looking at the tissue architecture. Because for certain lymphomas, you need to prove effacement of architecture to diagnose it, right? So that's what we have done. Now, like you said, we can also do right. We can also do a lumbar puncture, right? In certain scenarios. So lumbar puncture is usually done in Burkitt's lymphoma in all cases and high-grade lymphomas with involvement of those high-risk sites, right? Testis, ovary, breast, kidney, adnexa, or if there's a high CNS IPI score, or close proximity to CNS structures like paraspinal location, all that you can do lumbar puncture. Or Burkitt's lymphoma, do it in all cases. Okay. So this is the workup that you should say. Workup and diagnosis, CBC bio, rule out TLS, do a PET CT, bone marrow biopsy if required, if indicated, especially you can omit it in Hodgkin's and DLBCL. Excision biopsy should be done, and lumbar puncture in Burkitt's lymphoma or high-grade lymphomas with high risk for CNS spread. Okay, so that's the workup for diagnosis and staging. Now, here you should know the histopathology of certain lymphomas, namely DLBCL, Burkitt's lymphoma, um,
Hodgkin's.
disease, and you can also know this thing for CLL. Okay, and follicular lymphoma. So you need not know the HPV, HPE or all lymphomas. That is impossible. No one knows that. But DLBCL, Burkitt's, follicular lymphoma, and Hodgkin's and CLL. These five, you are good to go. Okay, so these five are the ones we're going to discuss today. The other ones are not needed for your practical exams. So we'll start off with DLBCL first. Okay. So DLBCL, you have complete effacement of the nodal architecture. So this is a more zoomed in version, but if you take a wider view, you'll have complete effacement of the nodal architecture. You will have large sized pleomorphic lymphoid cells. So large sized cells that look different from each other. You can see it here. They're large cells that are twice to thrice the size of a small lymphocyte that are pleomorphic. They're all different from each other. And they have high NC ratio and high mitotic rate in an inflammatory background, right? So these are all important features. Effacement of nodal architecture, large size of lymph node, pleomorphic nature, different from each other, then high NC ratio and mitotic rate, inflammatory background. Then one more thing here is that the Ki-67 index is raised. Usually it is up to 95%. Rarely you'll see it go above 95%, right? It'll be raised, but up to 95%. Then IHC is very important. So you have the B cell markers. Okay. So B cell markers are CD19, CD20, CD79B. Okay. Then you have the germinal center markers. So if the lymphomas arise from the germinal center, you'll have CD10 and BCL6 positive. Okay. So those are the common markers for DLBCL. Rarely you will get c-MYC positivity. So c-MYC positivity is very rare in DLBCL, and BCL2 can be positive in DLBCL. It is more commonly seen in DLBCL. Okay, so B cell markers, germinal center markers, c-MYC rarely seen, very rarely seen. BCL2 can be positive. So that's the general thing. Now, very important. Once you're done that, this is another question they'll ask you. How do you differentiate the two subtypes of DLBCL are?
Um,
And Solgar.
Yeah, so the two subtypes of
GCB and non-GCB by Hans algorithm.
Yeah, so activated B cell
and
and
germinal center base.
okay. So this ABC generally will be negative for CD10 and BCL6,
CD10.
which are the germinal center markers. Okay, it will be
Yes.
MUM1 positive, and
Normal.
usually it is associated with a more aggressive course. Okay,
ABC type.
yeah. So now you are the two algorithms. Can you name some the Hans algorithm? Can you describe?
Hence, we first look at CD10. If it comes positive, then it is a non-GCB type, and if
It is GCB type. If it is
GCB type, and if a CD10 comes negative, we will look for BCL6, and BCL6 if comes positive, and then we'll look for a MUM1. MUM1 if positive, it is a ABC type, and if MUM1 is negative, then it is GCB type, and if BCL6 is negative, then it is non-GCB type.
yeah, so you'll do CD10 first if positive, germinal
And
center. If it is
uh,
negative, then you look for BCL6. If that is
BCL6,
positive, you need to do
MUM1,
MUM1. That is negative, it is
negative.
GCB.
GCB and positive, then ABC.
Yeah. So if BCL6 is negative, it is BCL6 and CD10 is negative, it's definitely non-germinal center. So
Not
Hans algorithm, remember that. You can also remember this tally algorithm. So one is
Koi,
it, but
Koi
tally,
also.
Choi, other ones are also there. Okay. So now once you have done, you can differentiate ABC and what is the best way to differentiate between ABC and germinal center DLBCL?
CD5 and CD.
So these are algorithms that are old. Currently use genetic expression signals.
Gene
Okay.
expression.
Yeah. So gene expression profiles are used to
Yes.
differentiate this cell version. Okay. That is the
Mm,
best, most accurate way.
mm.
Now, another thing you need to look at in the biopsy. So remember all these points when they ask you, okay, is double expression and double hit. Double expression and double hit have a poorer prognosis, might require intensification of treatment. It is so double expressor is seen in certain percentage of cases. Some percentage of those double expressor can be double hit. Okay. So not all double expressions are double hit, but some of the double expression can be double hit. So how do you do that? On IHC first, you look for
Double.
positivity of CMYC and BCL2. Okay. CMYC and BCL2 is positive on IHC, it is double expression.
Mm.
Next, once you see that on IHC, you need to see if it is double hit. That is your next step. Okay. So then you do CMYC and BCL2 on fish. So if you do on fish, if CMYC and BCL2 is positive, it is called double hit. There you need, so double expression currently we do not intensify treatment. There's no hardcore evidence for that. Double hit, we intensify treatment. We give stronger chemotherapy. Okay, we'll discuss that later. So that is one other thing. Cell aversion. So histopathology, IHC, cell of origin, and also double expression or double hit presentation, right? So all that you need to look in biopsy of a DLB cell. Every point is very important. Next is super important cancer, right? Burkitt's lymphoma. So when you look at this, I have put a cytology picture and a biopsy picture. So in the cytology picture, you can see these are medium-sized cells. They're not large, okay? They're medium-sized cells. So they're smaller in size. They have a round nucleus with a thin basophilic cytoplasm. So you can see it's a very large nucleus with a thin rim of basophilic cytoplasm, right? The cells are smaller, unlike DLBCL, and you have an intracytoplasmic lipid vacuoles. You can see these lipid vacuoles in the cytoplasm, right? So that is characteristics of Burkitt's lymphoma. Remember this. This will definitely be asked somewhere. Then when you come to the histopathology, you will get a starry sky appearance. Okay. So there you will see these small size lymphoid cells, sorry, medium sized lymphoid cells, right? That you can see here. So medium size, Burkitt's is medium size, and you will also see macrophages that have engulfed
Gingival body.
apoptotic tumor cells. Okay. So that is these light areas that you see, that is called starry sky appearance. Okay. So that is another thing that you'll see. Then here, Ki67 will be greater than 95. So it will be 95 to 99%. Okay. And IHC, once again, B cell markers are positive. CD19, CD20, CD17. Then it is also germinal center in origin. Okay. Burkitt's is germinal center in origin. So CD10 and BCL6 are positive. But here, unlike DLBCL, where BCL2 can also be positive, here BCL2 is negative. Okay. But unlike DLBCL, where CMYC is rarely positive, in Burkitt's, CMYC is always positive. Okay. And usually you get a translocation 814 that is seen in Burkitt's. Okay. So that is how you differentiate, look at the histopathology and IHC of Burkitt's, and you differentiate between Burkitt's and DLB cell based on the histopathology, medium-sized cells, the characteristic intracytoplasmic vacuoles, presence of starry sky appearance, IHC where BCL2 is negative and
Negative.
c-MYC is positive, which is unlike DLBCL, right? And the translocation. So all these features can separate Burkitt's from DLBCL. That is also another important point, how to differentiate between both. Okay. So now, before we get into Hodgkin's, so you should know something about BCLPDs, right? So I'd already discussed CLR in my class on splenomegaly, so I won't get into that again. And then, so BCLPDs, how do we classify? Okay, just this is one point they can ask you. Classification of BCLPDs, how do we differentiate based on IHC? So BCLPDs will have small lymphoid cells. Okay. So DLBCL at large, Burkitt's at medium size. BCLPDs will have small lymphoid cells. So first you'll do B cell marker, that is CD19 and CD20. If that is positive, you will do CD5 and CD23. If CD5 is positive and CD23 is positive, it is CLL, right? If CD5 is positive but CD23 is negative, you will do
Mantle
a
cell.
cyclin D1. If cyclin D1, so CD5
Positive.
positive but CD23 negative, we'll do cyclin D1. If cyclin D1 is positive, it is
Mantle cell.
mantle cell lymphoma. If CD5 and CD23 are both negative, you will do a CD10. If CD10 is positive, it is follicular lymphoma. Okay. Follicular lymphoma. So CD5, CD23 negative, but CD10 is positive. Okay. So first we did our B cell markers, then we are doing CD5 and CD23. Okay. So see, both CD5, CD23 are negative, but CD10 is positive, it's follicular lymphoma. But if CD10 is negative, then
then
we do CD25 and CD103. Okay. CD25 and CD103 are specific markers for hairy cell
hairy cell. Yeah.
leukemia. Okay. So if CD523 is negative, CD10 is also negative. We do CD25 and 103. If both those are positive, it is hairy cell leukemia. Okay. And if both those are negative, we do further testing and look for the presence of marginal zone lymphoma. So that is how that is an overview of how find out which BCLPD it is. That is also commonly asked. You can refer back to this video on YouTube to figure that out once again. Okay. So we have done our DLBCL Burkitt's, BCLPDs, how to classify. Quickly, we'll go through follicular lymphoma. So follicular lymphoma is differentiated into grade 1, 2, 3A and 3B. Grade 1, so in the biopsy, you'll have centrocytes and centroblasts. Okay. So grade 1, 0 to 5 centroblasts with presence of centrocytes. Grade 2 is 6 to 15 centroblasts with presence of centrocytes per high power field. And 3A is greater than 15 centroblasts with presence of centrocytes. 3B is diffuse or sheets of centroblasts with no centrocytes. Okay. So know the grading, what it constitutes, how it's different. And so that's follicular lymphoma. That's not that important as DLBCL or Burkitt's. Now, very important is the next one. This will also be asked either in your practical exam, case presentation or in your Viva. Okay. So Hodgkin's disease, you should know the histopathology is very important. Okay. So usually you will see in although the subtypes can vary a little bit between the subtypes, right? But usually what you'll see is you will see the Reed-Sternberg cell. Okay, so you can see this in the center over here. So it is a giant cell with multi-nucleation, right? And classically it is bilobed or mirror image nuclei. And basically it has, if you look in the center, you can see eosinophilic nucleoli. Okay, surrounded by a halo. So eosinophilic nucleoli surrounded by a halo, bilobed multi-nucleated, right? With the mirror image nuclei bilobed with eosinophilic nucleoli in the center. Okay, so with a halo around it, it's also called owl's eye appearance. Okay, and you have abundant inflammatory cells in the background. Okay, now example, they will ask you over here, what are the subtypes? So what are the subtypes of Hodgkin's disease?
Hodgkin lymphoma is nodular sclerosis, mixed cellularity, lymphocyte depleted, lymphocyte predominant.
Yeah. So Hodgkin's is divided into classical as well as NLPHL, right?
Mm.
So within classical, you have nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depleted. Worst prognosis, lymphocyte depleted, whereas lymphocyte rich has the best prognosis. So within classical Hodgkin's, overall NLPHL has the best prognosis. So nodular sclerosing will have the same HPE, except you will have strands of fibrotic strands. Okay, thickened uh, fibrotic strands will be bands will be seen, which is where the name comes from, nodular sclerosing. Okay. Then mixed cellularity, you will have more variety of inflammatory background. So you'll have, lymphocytes, eosinophils, neutrophils, etc. So, and you'll have less fibrosis. Unlike nodular sclerosing, you'll have less fibrosis. Okay. And lymphocyte rich and depleted, the name itself suggests what is. You'll have less lymphocytes or more lymphocytes, lymphocyte rich or depleted. Okay. So that is the histopathology. And now, something you need to know here is that of NLPHL. Okay. So this NLPHL, usually what you'll get tend to get is you'll have nodular lymphocytic proliferative Hodgkin's, right? So you'll have nodules of small size B cells with the presence of LNP cells or popcorn cells. So you can see it in this image here. LNP cells is a variant of Reed-Sternberg this cell where you'll have large polylobated nuclei with smaller multiple basophilic nuclei. So unlike the eosinophilic nuclei in Reed-Sternberg cell, here you have a polylobated cell that is a popcorn cell, and you'll have, unlike eosinophilic, you'll have basophilic nuclei within the cell. Okay, so you can see that here, right? That is how you see find out its NLPG. You have nodules of B cell, small B cell lymphocytes with popcorn cells or
Like you.
LNH cells with polylobated nuclei with basophilic nucleoli inside. Okay, so that's how you differentiate. Okay, now coming to the IHC, it is very simple. Hodgkin's is CD50 and CD30 positive. It is negative for the B cell markers, whereas NLPHL is CD20 and
Twenty.
CD45, CD79A and PAX5 positive, right? And it is more likely negative for CD15 and 30. That is how you differentiate based on IHC. Okay. What are some of the DDs for NLPHL based on histology? So that's a slightly histopathology. It's a slightly tough question. Even I couldn't answer that in my exam. It is ALCL and B cell rich T cell lymphoma. Okay. So those are the two HP, differentials that they tend to ask. So I hope you got that. Histopathology for lymphomas, these are the important sites. They will definitely ask this. Be prepared. If you can say it quickly, the exam will, it'll just move smoothly to the next site, right? The next questions. So when you come to your lymphomas, another thing that you should know here is your so you have various IPS scores, FLIPP score for follicular, you have IPS score for DLBCL, you have MIPI score for mantle cell lymphoma. You need not remember all these scores, but remember IPS score for DLBCL. Okay. So what are the components? Can you name them?
Age, age more than 40, 45 year, ECOG PS, and more than 2, Ann Arbor staging 3, 4, serum LDH, and extranodal involvement, more than equal to 1 extranodal involvement,
Yeah.
and
So basically, age greater than 60 years, LDH greater than upper limit, ECOG 2 or more, stage 3 or 4, and greater than 1 extranodal involvement. Okay. So that comprises IPI. It's divided to low, 0, 1, low intermediate score of 2, high
intermediate,
intermediate
high
score of
inter.
3, high is 4 or 5. Okay. So based on that, the survival varies. Now, CNS IPS score is the same thing, but you also add involvement of
Adrenal
kidney.
and kidney.
Yeah,
Yeah,
the
last.
involvement of kidneys and adrenals. Okay, so just know that IPA and CNS IPA they tend to ask.
Okay.
Now, so once you have mentioned this, they can ask you what is the stage of this lymphoma. So staging is also very important. So usually earlier we use the Ann Arbor staging that is modified by Cotswold, right? To include what to define what is bulky disease and also what is external disease, right? So they give X and E. So Lugano staging, you should know it in depth. So stage one is if you have a single group of lymph nodes that are involved, or if you have a single extranodal site that is involved. Stage two is either you have two groups of lymph nodes that are involved on the same side of the diaphragm, or you have an extranodal site involved along with contiguous nodes involved. Okay, so I'll give an example of that. So you can have stage 2E. So stage 2 is basically stage 1 is single lymph node involvement, or it can be a single extranodal site. That is stage 1E. For example, if you have tonsil only involvement, that is stage 1E, right? If you have cervical only involvement, that is stage 1, for example. Stage 2 is two groups of nodes on the same side of the diaphragm. Or it can be external site with contiguous lymph node involvement. So what does that mean? For example, if you have colon involvement with involvement of the surrounding mesenteric nodes, right? That is, external side is involved, but also the surrounding nodes are involved, not some distant node. Okay, if the surrounding lymph node is involved, that is considered to be stage 2E. For example, if you have tonsillar mass with involvement of cervical nodes, that is stage 2E. Okay, tonsil is external site. The contiguous lymph node, the draining site is involved, lymph nodes involved. So that is stage 2E. Okay, then stage 3 is supradiaphragmatic involvement or involvement of the spleen with supradiaphragmatic involvement. Okay, stage 4 is
Diffuse involvement.
disseminated disease. So if you have suprainfantile nodal involvement with external involvement, that is stage 4. There are certain sites which automatically become stage 4E. That is if stage 4. So if certain sites are external sites are involved, you cannot put them under stage 1E or 2E. There is no stage 3, by the way. So you cannot put them under stage 1E or 2E. Those sites are liver, bone marrow, if you have multiple lung nodules, or if you have CNS involvement. That automatically comes into stage 4. Okay. So always remember that. That is also very important. Another thing is that yeah. So that is the Lugano's staging. Know your staging. They'll ask you various questions in staging. Another thing is, as per Lugano, unlike Ann Arbor and Cotswold, the prefix B for B symptoms is only used in Hodgkin's. Okay. Do not mention this in the exam. Use your normal, if, for example, if it's a stage tonsillar lesion with cervical nodes, say it is stage 2E, stage 2AE. Okay. Right? X is used if there's any bulky nodes that's greater than 10 centimeters for DLBCL. For folliculars, it is greater than 6 centimeters. So those are it's use your letters to denote whether it's B symptoms are present, whether it's bulky disease, that is X, whether there's external invasion, that is E. Okay, you can use that, but just if the examiner asks you regarding the updates, currently we do not use B symptoms for non-Hodgkin's. It is only used for Hodgkin's. That is an update. Don't say this in the exam when you're saying the staging, but you should know this separately if they ask you. Classically, it is used, but currently that letter is only used for Hodgkin's. And the letter X is not used. You just mention in brackets the largest dimensions. Okay, so that is some modifications done as per Lugano. But classically, Ann Arbor and Cotswold use all the letters and all that. So that is staging and risk stratification. Okay, so we have done a workup for diagnosis and staging. Now coming to a workup for treatment, you will repeat a CBC bio if needed. You'll do cardiology if you're giving anthracyclines, right? You will do workup for rituximab clearance. So what all will you do there?
Screening for hepatitis B, core antibody, HIV.
Yeah, so basically we are trying to look out for the presence of hepatitis B infection.
Hepatitis B.
So you'll do an HPSAG and you'll do an anti-HPC IgM and anti-HPC IgG or total. Okay, if any of these are positive, then you need to go to HPV DNA PCR. Okay, so if it is positive, you need to even if any of these are positive, that is HPSAG, anti-HPC, IgM, and IgG or total. If they are positive, then only you do a HPV DNA PCR. So if total or IgM is active infection, total is remote infection, then you look at the viral load as well if any of them are positive, and you have to start the patient on tenofovir 300 mg OD or tenofovir AF 25 mg OD or entecavir, right? So all these need to be started prior to treatment. Then one more thing you look at is fertility preservation as well, if the patient is young. So repeat your blood test, do cardiology, look for hepatitis B, for rituximab clearance, then fertility preservation. So that is what we do for a non-Hodgkin's lymphoma, right? So for Hodgkin's disease, you won't look for rituximab clearance because we don't give rituximab in Hodgkin's, but you will do an added test of pulmonary function test, right? So there you'll do what is the most important component of pulmonary function test, and why do we do it for?
DLCO,
Yeah, so DLCO is done, and we look bleomycin, right?
bleomycin pulmonary
We do
fibrosis.
it for bleomycin. So we need to know we need to know the absolute contraindications and relative contraindications. So the incidence of bleomycin pneumonitis is around 10% in Hodgkin's disease, and the absolute contraindication includes DLC of less than 30. Relative contraindications are DLC of 30 to 60, age greater than 40, uh,
40.
the
Creatinine
if
of
cumulative dose of greater than 400, if RFT is deranged, the patient is planned for thoracic RT, if the patient has a history of smoking, or if the patient has a history of COPD or other uh, toxicities. Here in Hodgkin setting, if you're giving a bleomycin based regimen, do not give GCSF. Okay, so that avoided at all costs in case of Hodgkin's. So, yeah, now we come to so we have done our diagnosis for workup, staging, and treatment, right? If it's Hodgkin's, you need not do clearance for rituximab. You do your pulmonary function test for uh, this bleomycin, right? So that is a workup for treatment done. So we have done our workup. That's all the questions they can ask you in workup. I think we've discussed most of them. So next thing we need to know here is we'll get into the management of the commonly asked lymphomas. Okay, there are 100 lymphomas out there. Even the examiners don't know the management of all of them. You need to know the management of the commonly asked lymphomas. Okay, and I will only talk about that today so that you'll do it for exam. So this is an exam focused, you know, uh, list of lymphomas that it can ask you the management of, right? So we'll start off with DLBCL. Okay, diffuse large B cell lymphoma. So diffuse large B cell lymphoma. So we'll first talk about involvement of stage 1 and stage 2. Very rarely seen, usually you get advanced disease in DLBCL. So stage 1 and stage 2, what are the treatment options? Yeah, okay. I'll just mention them. So stage 1 and stage 2, the treatment options are you can give 6 cycles of R-CHOP, right? That is one option. Another option is you can give 3 cycles of R-CHOP followed by IFRT, right? That is based on the SWOG trial. And another option, the third option is based on the FLYER trial, right? That FLYER trial compares 6 cycles of R-CHOP versus 4 cycles of R-CHOP followed by 2 cycles of rituximab alone. Okay. So the FLYER trial, they looked at patients with with IPS score of 0. Okay. So patients with IPS score of 0 could get away with omitting 2 cycles of CHOP. So you can give 4 cycles of R-CHOP and 2 cycles of rituximab only. So stage 1 and 2, you can give 6 cycles of R-CHOP, 3 cycles of R-CHOP followed by IFRT, or 4 cycles of CHOP followed by 2 cycles of rituximab if the the IPS score is 0. Okay, so that is how you manage stage 1 and 2 disease. Now moving on to stage, right. So moving on to stage 3 and 4, advanced disease, the treatment of choice is R-CHOP into 6 cycles plus or minus radiation to the bulky sites. Okay. So that is how you treat stage 3 and 4. R-CHOP into 6 cycles plus or minus radiation to the bulky sites or the external sites sometimes. So can you describe to me how you'll prescribe the R-CHOP regimen with all the pre-medications, everything?
So we'll first start with
So
medication
someone
for
asked the trial
rituximab,
name for 6 cycles of R-CHOP. It is the MAPTHERA trial. Okay.
MAPTHERA trial.
Yeah.
Yes.
Okay. Okay. So yeah,
So
please. Sorry.
Avil, yeah, Avil 2 cc, and then we'll give a hydrocort of 100 mg, and then PCM injections 1 gram IV stat, and then we'll give rituximab 375 mg per meter square. We'll start with a infusion rate with 50 ml 50 ml per hour, and then we'll if there is no reaction, then we'll gradually increase it to after 30 minutes, we'll increase it to 100. And then after every 30 minutes, we'll keep on increasing till it reaches 200 ml per hour. And then we'll yeah, finish it off within 4 to 6 hour time. And then we'll give, after rituximab, we'll give this one injections, dexamethasone 8 mg, injection ondansetron 8 mg in IV push, and then we'll give cyclophosphamide of 750 mg per meter square in 500 ml NS over 90 minutes, and then doxorubicin at the rate of 50 mg per meter square into 50 ml NS over 90 minutes, and vincristine will give a slow IV push, it is 1.4 mg per meter square, and the prednisolone 100 mg flat dose day 1 to day 5.
Yeah. So I like to make some changes there. Okay. So I'll just repeat what you said. I mean, the doses are all right, but administration, there's certain corrections I'd like to make. So RCHOP regimen, right? Pre-medication, first you start off with rituximab pre-medication. So you give your injection Avil, right? You give Hydrocort, 100 mg IV. You also give tablet or injection paracetamol. Okay, you've given your three pre-medications. Next, you're moving on to rituximab. Rituximab, you should start off, as per the FDA label, you should start off at 50 milligram per hour. And every 30 minutes, you should increase by 50 milligram per hour. So if, suppose 50 milligram per hour you give for first 30 minutes, you'll increase to 100 milligram per hour, right? So you'll keep on increasing by 50 milligram per hour every 30 minutes, and you'll complete the infusion usually in 4 to 6 hours, like you correctly said. Maximum infusion rate is 400 milligram per hour. You should not go beyond that. Okay. That is for the first infusion. For subsequent infusions, you can start off at 100 milligram per hour and increase by 100 milligram per hour every 30 minutes based on tolerance. Maximum infusion rate, once again, is 400 milligram per hour. That is how it is given FDA label. In most Indian settings, we give it as, we'll take 500 ml of NS, then we will give 100 mg as test dose over 1 hour, and the remaining dose we will give, suppose you have 750 mg that you need to give, 100 mg you'll give over 1 hour in 500 ml of NS, and remaining 650 mg you will give it, right, at increments over of 50 milligram per hour every 30 minutes. Okay, so that is how we give it in the Indian setting. So usually it takes 1 hour for that 100 mg. Remaining dose we usually give it over 3 hours. That is what happens in the Indian setting. But so you can say in our institute we give 100 mg over 1 hour and 500 minutes as initial dose, and then subsequently you give it for the remaining dose with increments of 50 milligram per hour every 30 minutes, and usually over 4 hours in our institute. Whereas in the FDA label it is given differently, right? So both you should know how it is given in Indian setup and how it is given as per the FDA label. So you have given your pre-medication for rituximab, you've given rituximab. Following that, you need a 3-hour gap between chemotherapy and rituximab. Okay, 3-hour gap is required for all the CD20 cells to be adequately, bounded by rituximab. Okay, then you give your chemotherapy. So 3-hour gap after giving rituximab, then you give your chemotherapy. When you're giving chemotherapy, give your pre-medications. Pre-medications include Emiset and PAN40. You need not give DEXA here. I'll tell you why. Okay, Emiset and PAN40 is enough. DEXA we are not giving in RCHOP. Next, you'll start off with your vesicants. So what are the vesicants? First, always give your vesicant. So doxorubicin, strongest vesicant, give that 50 milligram per meter square over 15 minutes. Okay, so you can give it in 15 minutes in 100 ml. Then you'll come to vincristine. Vincristine, you can give it either as a slow bolus with, continuous saline drip in a two-way line, or you can give it in 100 ml NS over 15 minutes. It depends on your institute, follow your protocol. So next we'll give vincristine 1.4 milligram per meter square, like I said so. And then next you will give cyclophosphamide, that is 750 milligram per meter square. You'll give that over 15 to 30 minutes. Okay, you can give that over in 100 ml NS. So that is how you give your chemotherapy. Also, you will give tab prednisone 60 milligram per meter square day 1 to 5. Okay, so that is the RCHOP regimen. Post chemotherapy, you can give Emiset 8 mg BD for 3 days, And also you give your pan 40 along with your steroids, which are also given for 5 days, right? So steroids, tab, Vicelon, 60 mg per meter square, day 1 to day 5 is also given. That is why you don't give Dexa, because you're giving steroids from day 1 anyways in the form of Vicelon. So that is the R-CHOP regimen. All these points that I mentioned, especially how to administer rituximab. In the FDA label, it is given one way, 50 milligram per hour, increase every 30 minutes by 50 milligram per hour, maximum 400 milligram per hour, right? That's for the first infusion. Second infusion onwards, you can start off at 100 milligram per hour and increase by 100 milligram per hour every 30 minutes and maximum 400 milligram per hour. Okay, that is the second infusion. Indian setup, you give 100 mg or 500 ml over 1 hour, remaining dose in 500 ml over 3 to 4 hours. Okay, that is how it's given in Indian setup. We don't go into all those complexities. So know all of that. R-CHOP regimen, nail it pakka. We do not give primary prophylaxis for R-CHOP regimen. Does not have a high risk for febrile neutropenia. Okay. So we give secondary prophylaxis if needed. That is another thing you need to know. Now, very important here is to know your drug, that is rituximab. Okay. Rituximab you should know, right? So rituximab is a type 1 anti-CD20 antibody medicine. Type 2 is obinutuzumab, right? It's another anti-CD20. So rituximab, basically rituximab, unlike obinutuzumab, rituximab is type 1. It acts mainly via this, right? It acts mainly via CDC, okay, complement dependent cytotoxicity, whereas obinutuzumab acts via antibody dependent cellular cytotoxicity. Okay, so note those two differences. Now you should know the routes of administration. So the dose in mostly R-CHOP is 375 milligram per meter square. You can also give it as subcutaneous dose. It is approved in DLBCL and follicular lymphoma subcutaneous dose. When you're giving subcutaneous, first dose should be given as IV, 375 milligram per meter square. After the first dose, you can give the remaining dose as subcutaneous. That is 1,400 milligram subcutaneous. Okay. So that is how you give subcutaneous. It can also be given IT, around 25 to 50 milligram max. It can be given as IT. So that is another route of giving it. Okay. Now, another thing you should know is the side effect profile. So side effects, toxicities can include infusion reaction, like we discussed. Then it can cause reactivation of hepatitis B, right? It can also cause other rare, infections like JC virus can cause, multifocal leukoencephalopathy. It
Yeah.
can also, CMV virus can be activated, right? So all these viruses can also be activated. Main is hepatitis B, but also JC virus, multifocal leukoencephalopathy, CMV virus, etc. Then, apart from that, it can cause skin toxicities, especially the subcutaneous formulation. It can cause reversible posterior leukoencephalopathy syndrome, right? It can cause pulmonary pneumonitis, ILD as well, okay, on prolonged use. And it can, if the patient is, got a bulky disease, is aggressive NHL, it can cause TLS, right? So all these toxicities you should be aware of when they talk about rituximab. You should know about the types of anti-20 CD20 antibodies, or rituximab and obinutuzumab. Rituximab is CDC mechanism of action. Obinutuzumab is ADCC mechanism of action. Okay. So obinutuzumab is not approved for DLBCL. It is approved for follicular lymphoma only, right? So that also you should know where it is approved. So I just mentioned that because we're talking about anti-CD20 antibodies. So rituximab, know all the side effects, know the doses, know the indications, know the routes of administration, all of that you should be aware of. Okay. Now, what is an update to giving R-CHOP in advanced DLBCL? Do we have any other data of more, efficacious treatment apart from R-CHOP? So it is the POLARIX trial. Okay. So there we give,
Polarics.
yeah.
Polar arts.
Yeah, so we give, so polatuzumab vedotin. Vedotin can cause neuropathy. So that is an anti-CD79B
Time
inhibitor.
be. Yeah.
Okay, just it is an ADC targeting anti-79B, CD79B, and it can cause neuropathy. So we omit vincristine. So we give
Polar arts.
Pola R CHP. Okay, into
CH.
6 cycles. Benefit is that it has benefit of only DFS. There is no OS benefit. Okay. So DFS benefit around 6% is seen. We generally tend to give it in patients with IPS score of 2 or more. Okay. So IPS score of 2 or more, or if the patient has ABC type, or if the
And
patient is elderly. So that
age.
DFS benefit is
Yeah.
important in elderly, because we cannot take them up for transplant if they recur. So we need
Yeah.
that DFS benefit. So elderly, ABC, IPS score of 2 or more. Okay, that's where we give this polar RCHP. Now, one more thing you need to know is treatment of, okay, if there's cardiac toxicity, how do we give? Uh, so if there's cardiac toxicity, we can consider replacing anthracycline with etoposide, right? If the patient has a pre-existing cardiac toxicity. If the patient is frail or elderly, we can give R mini chop, or we can omit anthracycline and give R CVP as well. Okay, so those are other options depending on other comorbidities. Now, very important here is the treatment of relapsed and refractory DLBCL. Okay. So when it comes to relapsed and refractory DLBCL, you should know that earlier the treatment of choice was salvage regimen, either ICE, DAP, right?
Then,
Or so R-ICE, R-DAP,
sure.
GDP, followed by bone marrow transplant. Okay, so if you have a recurrence, always do a repeat biopsy. Always do a repeat PET. Okay, so that is very important. So do all of that and then establish that it is DLBCL recurrence. Then give salvage regimen with RICE, RDAP, RGDP, 2 to 3 cycles, followed by reevaluation with PET-CT, followed by autologous transplant. Okay, so that was the treatment of choice for all relapsed refractory cases. Currently, for patients who are refractory and for patients who have relapsed early, less than 12 months, we currently give CAR T cell therapy. Okay. So we have two approved agents, axicabtagene ciloleucel and lisocabtagene maraleucel. So axicabtagene is based on SUMA-7 trial. Lisocabtagene is based on the Transform trial. Okay. So those are the two approved agents in refractory or relapse less than 1 year. In relapse, patients who have relapsed greater than 1 year, you still give salvage chemotherapy followed by autologous transplant. Okay. And in this autologous transplant, so salvage chemotherapy, 2 to 3 cycles in the regimens I mentioned for patients who have relapsed greater than 1 year only, followed by autologous transplant. Whereas for refractory or relapse less than 1 year, you give CAR T cell. So know this differentiation. Now, if you have relapsed greater than 1 year, giving salvage chemotherapy followed by transplant. In the transplant, the regimen that is commonly used is BEAM. Okay. So that consists of carmustine, etoposide, cytarabine, and melphalan. So BEAM regimen is used in the relapse setting greater than 1 year for transplant post salvage chemotherapy. Okay. So I hope you got that. Salvage chemo in relapse greater than 1 year, salvage chemotherapy 2 to 3 cycles followed by transplant with BEAM regimen. Okay. Autologous transplant. So that is how you treat relapse refractory DLBCL. Now, let us move on to the next site. Next site that we'll discuss is Burkitt's lymphoma. Okay. So you should know the management of your Burkitt's lymphoma. So what are the types of Burkitt's lymphoma?
Endemic, African variety, sporadic, and immunocompromised HIV associated.
Yeah, so those are the three types. Now, when you come to
Three types.
your Burkitt's lymphoma, you should always look at the risk factors that are present. Okay. So risk factors so if no risk factors are present, you take it as low risk and the treatment is different. If any one of these risk factors are present, it is high risk. So what are these risk factors? If you have raised LDH, if ECOG score is 2 or more, if you have stage 3 or 4, if you have greater than one extranodal site involvement, if the tumor size is greater than 10 centimeters, if there's CNS involvement. So if any of these features are there, it is considered to be high risk and it is treated differently. Okay, so low risk and high risk, you should subclassify first. That is job number one. So once you have done that, next, you have various regimens. Okay, so I'll give three options that you can treat in Burkitt's lymphoma. Now, they'll definitely ask you, what are the principles of chemotherapy in Burkitt's lymphoma?
Um, it should be highly intensive chemotherapy so that there will be less cross resistance and like different regimens to be combined like McGrath where
Yeah. So I'll just quick, because we need to cover all this stuff. I'll just quickly go over it. Okay. So we need prompt treatment, start off treatment very quickly. Second thing is you need to be dose intense. So a high dose of chemotherapy should be given. Third thing is you should be dose dense. So there should be a short interval between each cycle, right? Second, you should use multi-agent chemotherapy that is non-cross resistant, which is how we have designed the therapies. And the third thing is you need to give CNS prophylaxis. And the last thing is give anti-TLS prophylaxis, right? So prompt, dose dense, multi-agent with no non-cross resistance, CNS prophylaxis, and give your anti-TLS prophylaxis. Burkitt's lymphoma can cause spontaneous TLS, right? So that also you need to be aware of. So what are the treatments given? So for low risk, so the McGrath regimen, you give it based on whether it's low risk or high risk. If it is low risk, you give R-Codox M into 3 cycles. Okay. So R-Codox M into 3 cycles for low risk. So that consists of rituximab, cyclophosphamide, vincristine, doxorubicin, high-dose methotrexate, along with intrathecal chemotherapy as well, right? So R-Codox M into 3 cycles for low risk. For high risk, you give R-Codox M alternating with IVAC for
I
4 cycles. So 1 cycle of R-Codoxim followed by 1 cycle of IVAC, followed by R-Codoxim, followed by IVAC. So 4 cycles in total. Okay. So R-Codoxim, we said IVAC is ifosfamide, VP60, that is etoposide, and
did
Aracid. Okay. So that is how you give for high risk. Okay. That is one treatment regimen. That's a McGrath regimen. Second, you can give hyper CVAD. Okay. Hyper CVAD, 4 cycles you can give. Uh, Third regimen is ARDA epoch. Okay. ARDA epoch, that is dose adjusted epoch can be
dose
given
adjusted.
for Burkitt's lymphoma. Usually we don't prefer ARDA epoch. We usually give hyper-CVAD or R-Codox with IVAC. But ARDA epoch we can give, especially the patients HIV positive. In that case, they may not tolerate more intensive chemotherapy. So there you can give ARDA epoch with intrathecal prophylaxis. Okay. What are the other settings where we give ARDA epoch in lymphoma?
In lymphoma, like in primary mediastinal B-cell lymphoma, and in early stage DLBCL.
Yeah, so I'll just quickly mention them. So one we have mentioned Burkitt's lymphoma we can give,
Burkitt's cells,
primary mediastinal B-cell
PMBCL,
lymphoma can give, and double hit DLBCL. Okay.
double.
Okay. So in those cases we tend to give. And also in plasmablastic lymphoma, there also we give not R-DAPOC, we give dose adjusted epoch. That's CD20 negative, so we give dose adjusted epoch. Okay. So once again, PMBCL, double hit DLBCL, Burkitt's, and plasmablastic lymphoma. Okay. All that we can give.
Plasma.
Okay, so I hope you got that treatment of Burkitt's lymphoma, how we treat it, right? So McGrath is based on low risk and high risk, whereas other options are hyper CVAD and RDAPOC. RDAPOC usually give it in
Okay.
HIV positive. Principles of Burkitt's lymphoma you should know inside out. Okay, now moving on, we'll go to next. So DLBCL is most common NHL, right? Second most common is follicular lymphoma. Burkitt's is very unique. That's why they asked this. Okay, so we should know follicular
Rare.
lymphoma management. Okay.
Mm.
So when it comes to the management of follicular lymphoma, it is very simple. I'll just quickly mention it. So if it is so not all cases of follicular lymphoma require treatment. If it is stage 1 or stage 2, okay, stage 1 or stage 2, if the lymph nodes can be encompassed in a radiation field, there you treat the patient radically. Okay. So if you have stage 1 disease or stage 2 disease with contiguous nodes, that can be treated with RT only. That is considered to be radical treatment, curative treatment for follicular lymphoma. Okay. Stage 1 or stage 2 with contiguous nodes, radical RT. Rest of the patients, you cannot treat and cure the patient. Okay. So if you have stage 2 non-contiguous nodes, that is nodes present elsewhere, separated from each other, where you cannot give radical RT. Or if you have stage 3 or 4 disease, in those patients, you cannot give radical RT to cure the patient. So stage 2 non-contiguous or stage 3 or 4, you are not going for a curative intent. Okay. Because you cannot give curative RT because of extensive disease, right? So there you look at whether there is any criteria for treatment. Okay. So what are the criteria? Use the GELF criteria, GELF. So presence of 3 or more nodal sites greater than 3 or more centimeters. So presence of a node greater than 7 centimeters in size, right? All these are criteria. B symptoms, presence of splenomegaly that is symptomatic, presence of any cytopenia, right? So presence of peripheral effusion, ascites, or organ compromise. For example, the spinal cord compression or any other organ is compromised, organ function is compromised. So yeah, all these criteria are met, the GELF criteria. If any one of them are met, then you treat your stage 2 non-contiguous, stage 3 or stage 4. Otherwise, in stage 2 non-contiguous, stage 3 and stage 4, you can go for observation. If Guelph criteria is met, then and then only you treat the patient. Okay. So I hope you got that. So what are the options for treatment in a case of follicular lymphoma? So, like I said, stage 1 and stage 2 contiguous, you give radical RT. Stage 2 non-contiguous nodes, or 3 or 4, you observe. If Guelph criteria is met, you treat. What are the treatment options? So mostly there are 3 first-line treatment options. You can treat with R-CHOP into 6 cycles. Okay. R-CHOP into 6 cycles, or you can treat with BR into 6
Yeah.
cycles. Okay, bendamustine and rituximab. R-CHOP into 6 cycles, you can follow that up with rituximab maintenance given every 2 monthly for 2 years. Okay. So treatment option number 1, R-CHOP into 6 cycles. Treatment option number 2, BR into 6 cycles.
Yeah.
Treatment option number 3 is lenalidomide plus rituximab for 1 year. Okay. So those are the treatment options, 3 treatment options. When you're giving R-CHOP, there's data for giving rituximab maintenance that is given for 2 years, 2 monthly for 2 years. Okay, post giving R-CHOP into 6 cycles. So there's a still and bright trial. Both these trials showed that in indolent lymphomas, especially follicular lymphoma, there's a PFS benefit of giving BR over R-CHOP, but it is only a PFS benefit. There's no OS benefit. Okay. When you counsel the patient regarding whether to give BR, whether to give R-CHOP, or whether to give lenalidomide plus rituximab, these 3 options, you should always say that in R-CHOP, you can have cardiac toxicity, you can have neuropathy, you can have hair loss. Whereas bendamustine rituximab, you can give it in patients with cardiac toxicity, with neuropathy, or patients who do not want hair loss. But it can cause severe skin toxicity with bendamustine. Okay. So that's how you decide. The patient decides what treatment they want, right? You give treatment based on the patient in front of you. So first line option is BR alone, R-CHOP in 6 cycles followed by rituximab maintenance, or lenalidomide plus rituximab. So those are the 3 options. Okay. So that is what you need to give. I like to mention the dose of bendamustine rituximab. Once again, you give rituximab upfront, followed by 3 hours. Then bendamustine, you give it as 90 milligram per meter square. You give it day 1 and day 2. Okay. Okay. So I hope you got that. So 90 milligram per meter square, day 1 and day 2. Bendamustine is same alkylating. Even though you have given R-CHOP earlier, you can still give bendamustine rituximab. It can give it because bendamustine, although it is an alkylating agent, it has an extra mode of action, that is mitotic catastrophe. Okay. So unlike other alkylating agents, it also has an extra mode of action, that is mitotic catastrophe, through which you can give it even if you have given prior alkylating agents. Okay, so that is the interesting thing about bendamustine. So those are the 3 frontline options for your follicular lymphoma that you need to mention. With R-CHOP into 6 cycles, following that, you can also give rituximab maintenance. That is based on the PRIMA trial, which has shown a PFS benefit. Okay. So give R-CHOP into 6 cycles or BR into 6 cycles. If you have given BR, it's a PET-CT negative, then you need to keep the patient on follow-up. There is less evidence for rituximab maintenance. In R-CHOP into 6, do PET-CT if the patient is in CMR, right? You keep the patient, start the patient on rituximab maintenance if possible. And lenalidomide and rituximab, you give for 1 year. Okay. So those are the 3 options. Now in follicular lymphoma, based on the gallium trial, you can also replace rituximab with obinutuzumab. Okay. In all these 3, BR, R-CHOP, and lenalidomide plus rituximab, you can replace rituximab with obinutuzumab. So that is based on the gallium trial that has shown a PFS benefit. When you're giving obinutuzumab, you have to give it as, so it is given as 1000 milligram. Okay. So 1000 milligram is given as day 1, you give 100 milligram, day 2, you give 900 milligram. Okay. Then you give 1000 milligram on day 8, then you give 1000 milligram on day 15. So initial dose of obinutuzumab is a fixed dose, 1000 milligram. So you divide that into 100 milligram on day 1, 900 milligram to day 2. Then you give 1000 milligram on day 8 and 1000 milligram on day 15. Following that, you repeat it every 4 months. Okay. I hope you got that. So initially there's a loading dose on day 1, 8 and 15 of 1000 milligram. And following that, you repeat it every monthly. That is how you give obinutuzumab. Sorry. Now, follicular lymphoma, the thing you need to know is how do we So when you do a biopsy in a follicular lymphoma or any indolent malignancy, always do a PET-CT and do the biopsy from, even on baseline or on progression, do the biopsy from the site of highest SUV uptake. Okay, because there could be a possible transformation. So whenever you do it on baseline or do it on progression, do the biopsy from the site of highest SUV uptake, especially for indolent lymphomas like follicular lymphoma. That is very important on progression, right? You might do the biopsy from low SUV uptake. That might, you might think it's follicular lymphoma again, but it might have transformed, right? So we need to rule out transformation. Always do biopsy and progression from the highest SUV uptake place. So that is how you treat follicular lymphoma. Now coming to the next one, that is Hodgkin's disease. Okay, so these are the ones they tend to ask you. So you should know. Next one that you should definitely know is Hodgkin's disease management. So Hodgkin's disease is right. So it is divided. There are many things you need to know in Hodgkin's disease that are separate. Okay. So right. So Hodgkin's disease is divided into early as well as advanced. Right. So in terms of early, it is divided into favorable and unfavorable within early, right? Stage one and stage two is divided into favorable and unfavorable. That is based on certain criteria. So there's EORTC, there is GHSG, then there's also NCIC criteria. So just
CCA.
remember, yeah, one or two NCCN as well. So there are four of them. Just remember one or two. Okay, or the one you use in your institute. So I'll just read EORTC. Just study two and stick to those two. Okay. So ERTC is large mediastinal mass, age greater than 50 years, ESR greater than 50 without B symptoms, or ESR greater than or equal to 30 with B symptoms, or greater than 4 or more nodal areas. GHSG
With
is
reasons.
large mediastinal mass, external disease presence, ESR greater than 50 with or without B symptoms, or greater than 30 with B symptoms, and greater than or equal to 3 or more nodal areas. Okay. So that's GHSG. So that's how if one of these are present, it becomes unfavorable. Okay, so early disease divided into favorable, unfavorable based on these risk score. Study at least two of them. Now, you should also know the difference between, so in URTC, we use MTR, in GHSG, we use MMR. So MTR is maximum thoracic,
Mediastinal thoracic
right?
ratio.
Yeah. So
Something.
mediastinal thoracic ratio.
Mediastinal.
So this mediastinal thoracic ratio is max width of mass divided by intrathoracic diameter at T5 and T6 junction. Okay. So maximum width of the mass divided by intrathoracic diameter at T5, T6. We use that in EORTC. MMR is max width of mass divided by max intrathoracic diameter. Okay. So you should know the difference between MMR and MTR. MMR is significant if it's greater than 0.33. MTR is significant if it is what is the cutoff there? It is 0.35. Okay.
0.35.
Yeah. So MMR and MTR. You should know the difference. Okay. MTR is used in URTC and MMR is used in GHST. Okay. So know how to differentiate early into unfavorable and favorable. That is very important. No, study at least two criteria that are used, two groups of criteria. Usually can stick to ERTC and GHST. Okay. Now, moving on. So the treatment for your early favorable, right? Early favorable. If there are no risk factors, then you give 2 cycles of ABVD followed by you do a PET-CT.
20
So
days.
currently we do PET adapted therapy. Okay. There's no role for non-PET adapted therapy. So there are few exceptions, but mostly we do PET adapted therapy. So before we get into the treatment, I'll just mention one more thing. You should know the dual score. Okay. So can you mention what the dual score is?
Score 1, no uptake. 2, less than mediastinum. And 3, more than mediastinum but less than liver. 4, more than liver. Uptake is more than liver but it is moderate. And 5, more than liver but uptake is marked.
Yeah,
And
so markedly higher than liver, right? So that is the
new lesion.
dual score. So this PET adaptive therapy, there's no role in NHL. It's only there in this your Hodgkin's disease. Okay, so know the dual score. Dual score of 1 to 3 is considered to be a complete metabolic response. Okay, although 3 is slightly borderline, but 1 to 3 is generally considered to be CMR. Okay, so that's also another thing that you should know. So keeping that in mind, let's go to management. So early favorable, you would give 2 cycles of ABVD followed by reassessment by PET-CT. If in CMR, you go for radiation. We'll discuss
Two
the
more
technique
cycles.
later on. 20 gray, right? So 20 gray of radiation, involved field or involved nodal radiation, right? So 2 cycles of ABD followed by followed by PET-CT reassessment, followed by, if in CMR, give 20 gray to the site. So that's early favorable. Now, early unfavorable, there are various methods to treat it. Okay. So you give 2 cycles of ABVD, early unfavorable. So this early favorable treatment is based on the HT10 trial and the HT16 trial. Okay, you can go back and read those two trials, HT10 and HT16. That's early favorable. Coming to early unfavorable, based on the EORTC LISA trial.
HT14 and
Yeah.
17.
So EORTC LISA trial, you give ABVD 2 cycles. Okay. Then you do a PET-CT. If the PET is in CMR, then you give 2 more cycles of ABVD followed by consolidation
Two
with
more cycles.
40 gray
30,
IFRT.
30 grade.
Okay. So 2 cycles of ABVD, do a PET reassessment, then give 2 more cycles of ABVD if in CMR, and then give IFRT. 30 gray this time because it is
30
unfavorable.
grade.
If you have given 2 cycles of ABVD in early unfavorable and it is PET positive, then you can escalate it to escalated BIACOP regimen.
Yep.
Okay. So you give 2 cycles of escalated BIACOP regimen post 2 cycles of ABVD if PET is not in CMR. Following that, you can consolidate with IFRT. So if PET is not in CMR post 2 cycles of ABVD for early unfavorable, you give 2 cycles of escalated BIACOP. Then if in CMR, you consolidate with IFRT. Okay. In some institutes in early unfavorable, if 2 cycles of ABVD PET is not in CMR, then they do not give escalated BIACOP in certain institutes. So there they continue with 2 cycles of ABVD. The scenario that is done in PET negative, okay, because escalated BIACOP is not given in those institutes. So it depends on the institute, but ideally you should give escalated BIACOP if PET is CMR is not attained. Okay. Other institutes, if CMR is not in name, if there's no progression, they continue the ABVD 2 more cycles and give RT. Okay. Now, another option is sometimes you might want to omit radiation. Okay. In that setting, you can give 2 cycles of ABVD followed by, check the PET-CT once again. If it is in CMR, so this is for early unfavorable. Okay. This is an RT less option. That is 2 cycles of ABVD. Check the PET. If it is in CMR, you can give 4 cycles of AVD. You can omit bleomycin and give AVD alone. That is based on the RATHEL trial. Okay. So that is also an option in early unfavorable. That is a RT less option. Usually we give it for girls, young ladies with mediastinal mass and all, where we need to mediastinal irradiation can cause breast cancer and other secondary malignancies, right? So in those cases we tend to omit RT, or if there's any other contraindication, you can then give 2 cycles of AVD, make sure it is in PET CMR, then give 4 cycles of AVD based on the RATHEL trial. So early unfavorable, you can also do that. So I hope you got the management of early. Now, coming to the management of, so one thing you need to know here is that escalated BIACOP is not preferred nowadays because it can cause high infertility. Infertility rate is around 30%. It can cause secondary malignancies, higher rate of secondary malignancies, higher toxicity, including myelosuppression. And if the patient relapses later on, we might not obtain adequate stem cells for transplant also. Okay, so that is why escalated BIACOP, most people don't prefer it. We still stick with ABVD. Now, ABVD, you should know one thing, how to administer ABVD. So please, can you tell me how to administer ABVD? What's the prescription for it?
ABBD will start with MSET 8 mg injection, DEXA 8 mg, and Pantop 40 mg IV push, and then injection adriamycin 25 mg per meter square in 100 ml NS over 30 minutes. And then bleomycin, bleomycin is a slow IV push, that is 10 mg per meter square,
Yeah,
slow
so
IV push, or
I'll just correct that because we're running out of time, right? I'll just quickly mention it. Okay. So
10 units,
pre-medications,
10 units per.
yeah. So pre-medications, you'll give MSET 8 mg, DEXA 8 mg, PAN 40. You'll give all of that. Then you'll start off with the vesicants once again. So you'll start off with doxorubicin, 25 milligram per meter square and 100 ml NS over 15 minutes. Then you'll give vinblastine, that is given as slow IV push with a two-way drain with a running NS, that is given in 10 so yeah, 6 milligram, that is given as 6 milligram per meter square, right?
6
So
mg per
yeah,
meter.
so that is vinblastine. Then you should give bleomycin, that is given as 10
Blue.
units per meter square, that is given over 30 minutes, okay, in 100 ml. And then you give dacarbazine, that is given as 375 milligram per meter square, that is given over 1 hour, okay, in 300 ml. Post chemotherapy, you can give MSZ Dexa, and you can also add Dufalac, because vinblastine can cause, amotility of the bowel, can lead to constipation.
Constipation,
Yeah.
colitis.
So post chemotherapy, you can give MSZ Dexa, PAN, and a laxative as well. So that is how you give ABVD. You
And
give that on
GCS
day 1 and day
prophylaxis.
15, right? So day 1 and day 15, that is one cycle. Okay. So it's given every monthly, day 1 and day 15. So I hope you got that. Now, once we know AB, that they'll definitely ask you ABVD in Hodgkin's. So in advanced treatment of advanced, what are the options? Okay, currently the options include, you can go give 2 cycles of
Nivo
ABVD.
ABD.
Yeah. So if suppose a patient can't afford advanced treatment, in our setup, usually we give 2 cycles of ABVD followed by evaluation by PET-CT. If in CMR, you can switch over to 4 cycles of AVD. Okay. So Rathel trials also included advanced patients as well. So 2 cycles of ABD, do PET-CT. If in CMR, give 4 cycles of ABD. Omit the bleomycin. Okay. That is one option for advanced. Currently, with the latest advancements, like you rightly mentioned, you can give Nivo AVD, right? So you omit bleomycin in that setting. So you give nivolumab plus AVD day 1 and day 15, and you give that for 6 cycles. That is based on the SWOG 1826 trial, right? So that showed a PFS benefit over the previous thing, that is brentuximab vedotin and AVD. So we have discussed ABVD alone based on Rathral trial into 6 cycles. 2 cycles CMR, you give AVD into 4. Then the next evolution was the Echelon 1 trial. Okay, Echelon 1, they gave brentuximab vedotin plus AVD into 6 cycles. Yeah, BVAVD, that showed a PFS benefit over ABVD alone. The next evolution was based on the SWOG 1826 trial, that is Nivo AVD, right?
Nivo ABD.
Now, into 6 cycles. Now, one thing you need to know here is that this Nivo AVD and brentuximab vedotin AVD, there is no PET adapted therapy. You don't need to do an interim PET. You do PET-CT after 6 cycles. Okay, so that's for BV-AVD, brentuximab vedotin AVD, and Nivo AVD. There's no interim PET. Okay, recently you also had the HT21 trial, that is the BRCAD regimen. Okay.
CAD.
So BRCAD regimen, basically, it was, so that is also another option for advanced. So there they compared BRCAD versus escalated BFOP. So 2 cycles of BRCAD. For that, you did a PET-CT. If in CMR, you give 2 cycles of BRCAD. If not in CMR, you give 4 cycles of BRCAD. Okay. So that is the BRCAD regimen based on HT21. They compared that to escalated BFOP. It showed less toxicity, and it also showed DFS benefit. Okay. So that is also standard of care. So ABVD based on the Rathel trial, BVAVD, ideally, if affording, should give Nivo AVD. Okay. So Nivo AVD is preferred up there. If not affording BVAVD, that's slightly cheaper. If not affording ABVD, also you can give BRCAD regimen that consists of brentuximab vedotin as well. Okay, based on the HT21 trial. So these 4 options are there for the advanced setting. Okay. So now we'll just quickly wind up. You should also know the right. You should also know the types of radiation. They definitely will ask this question. So you have earlier you had extended field radiation like mantle field, etc. We have moved on from that to involved field RT. Involved field RT will encompass the entire region of the involved node. For example, if you have a cervical node, you'll irradiate all the ipsilateral cervical nodal regions. Okay. That is called involved field RT. You will irradiate the entire region of the involved node. So if you have a level 2 cervical node, you'll irradiate all the cervical nodes. Okay. Plus the SCF. So that, just giving you an example, involved field RT, you'll involve the irradiate the entire region. So just give this example to the examiner. If cervical node is involved, you'll irradiate all the cervical node levels from level 1 to level 5 plus SCF. That's an example of involved field RT. You irradiate the entire region. Then involved nodal RT or involved site RT. Those are the other two types, right? Involved nodal RT, what you will do is you will require a pre-chemotherapy diagnostic CT and a PET CT, okay, with the patient in the treatment position. Then you also require a post-chemotherapy CT scan, okay. So pre-chemotherapy PET CT and post-chemotherapy CT scan are required. Now what you do is you fuse both and you right. So you treat the gross tumor volume is the post chemotherapy mass. Okay, and so that is this taken as a gross tumor volume, and the clinical tumor volume on the CTV is the pre chemotherapy GTV. Okay, so the pre chemotherapy mass also you irradiate, include that in the volume, and you also so yeah, so you fuse both those together, and that is the volume that you irradiate. So post-chemotherapy is taken as GTV, CTV is the pre-chemotherapy volume, and you irradiate the node alone. Okay. So, and you can also irradiate the adjacent areas that were touched by the node. For example, if you have a cervical node that was invading on the sternocleidomastoid, you can also expand the clinical target volume to include the area of the sternocleidomastoid as well. So that is how you treat with INRT. Treat the node that is involved as well as the post-chemotherapy volume is the GTV, the gross target volume. Pre-chemotherapy volume is the clinical target volume with extensions that were present pre-chemotherapy. That is involved nodal RT. Involved site RT is when you do not have the pre-chemotherapy PET CT. In that scenario, you do not have enough information for involved nodal RT to be that precise. Right? So there you give, suppose I'll give an example of involved site RT. If level 2 is involved, a node is involved, you'll treat the node that is involved nodal RT plus the entire level 2. Understood? So you're treating the entire site. So you do not have the pre-chemotherapy PET CT, or you don't have all the information to treat involved nodal only. So you don't have the information to treat with that degree of precision. So you treat the entire site of the node that is involved. So for example, give the example to the examiner. If you have a level 2 node, you'll node in the level 2, you'll treat the entire level 2. That is example of involved site. So I hope you got the difference between extended RT, which is not practiced nowadays, involved field RT, involved nodal RT, and involved site RT. Okay, so that will also be asked in the exam. Just give examples that will let the examiner know that you know how it is given. Okay. Once again, relapse refractory cases, what you'll do is you will do a biopsy, you'll do a PET CT, and also then you will give salvage chemotherapy, either GDP, DAP, ICE. You will combine immunotherapy if not given earlier. You can combine brentuximab vedotin if not given earlier. Give 2 to 3 cycles, go for an auto transplant, right? And in auto transplant, the conditioning regimen is beam. So that is how you treat relapsed refractory Hodgkin's disease. Once again, 2 to 3 cycles of salvage, combined chemotherapy, DAP, ICE, or GDP, or GVD, combined with immune checkpoint inhibitors or brentuximab vedotin if not given earlier, followed by auto transplant. Also, there's an ATHIRA trial in which patients who relapse in less than 12 months or patients with extranodal extension, you can give brentuximab vedotin as maintenance as well, post-transplant in relapse refractory. Okay, so that is also another added point. So before we end our talk today, just the last point that I'd like to make is management of HIV positive aggressive lymphomas. Okay, so in HIV positive aggressive lymphomas, always remember these points, and I'll end the talk the session based after this point. Okay, so when you give treatment there, always, so HIV positive lymphomas, you should always do a lumbar puncture because they have high chance of CNS mets. Okay, they're highly aggressive, B symptoms, external extension, stage 4 disease, CNS mets. So always do a lumbar puncture. Always do a CD4 count to know the current status. Okay. Then look for cross-reacting drugs. So protease inhibitors are CYP3A4 inhibitors. So they can have interactions with drugs like anthracyclines and vincristine, etc. Sidovudine can cause myelosuppression. Then cobicistat is a CYP3A4 inhibitor that can also have interactions. So look for whether the drugs have interactions with chemotherapy. So CD4 count, added, you should also, apart from the regular workup, do CD4 count, do lumbar puncture, and look for cross-reacting drugs. in your art therapy. Okay. Always continue your antiretroviral therapy during chemotherapy. That is very important. Now, coming to always use primary prophylaxis if needed, especially if your CD4 count is low. Now, coming to the treatment, right? Uh, if the CD4 count is less than 100, especially less than 50, you should omit rituximab till it becomes less than 100, above 100. Okay, so CD4 count of less than 100, omit rituximab because it can cause severe infections. Okay, that is one point to note. Second point is, you can, if CD4 is low, you can still give chemotherapy, but you should always tailor the dose of cyclophosphamide. Trials have found that the dose of cyclophosphamide, if CD4 count is low, less than 100, the higher dose of cyclophosphamide can lead to higher mortality. So NCCN has given it very beautifully. If CD4 count is greater than 200, give 750 milligram per meter square cyclophosphamide. If CD4 count is greater than between 50 to 200, give 375 milligram per meter square cyclophosphamide. If CD4 count is less than 50, give 187 milligram per meter square of cyclophosphamide. So based on CD4 count, you should omit rituximab if less than 100. And if based on CD4 count, you should also tailor dose of cyclophosphamide. Okay. Usually we give R-CHOP regimen. You can also give ARDA-APOC regimen in certain settings, like such as Burkitt lymphoma, right? And that's when you give ARDA-APOC. So that is how you treat HIV positive DABCL. Remember all these points, they will definitely be asked. Okay. So based on CD4 count, based on drug interactions, all that you need to remember. So that's it. This is what they'll ask you in your exams. You need not worry beyond this. If you've studied this much, you'll be set for your lymphoma case. Okay. There are many other points that can be asked, small points, but this is the basic structure. Beyond this, it's very rare that they'll ask you any more questions. This is what they expect you to know. So hope you had a good session. So we'll see you all on Sunday for that master session on Grand Viva rounds and instruments and imaging, etc. Okay. So till then, take care. Good night. Thank you, Dr. Poonam, for presenting that case, and
Thank
all the
you.
best. Right. And so I'll call it a night. Good night.
Thank you. Good night.